Welcome to the funnel effect.
We are launching into a truly massive undertaking today, a deep dive into a document that will really redefine how we care for an entire generation of heart patients.
We are talking about the comprehensive 2025 Akahar Sexty Sec Guideline for the management of adults with congenital heart disease. Now, that is a stream of acronyms, but what it really represents is the unified consensus voice of, well, virtually every major cardiac and interventional society in North America and beyond.
It's a huge
A
collaboration.
huge one. And this monumental update was expertly guided by leaders like Michelle Gerbitz, MD, MS, and co-vice chairs Eric V. Krieger and Stephanie Fuller. And it was developed in collaboration with the Heart Rhythm Society, the International Society for Adult Congenital Heart Disease, and the Society for Cardiovascular Angiography and Interventions.
Our mission today is, I think, pretty straightforward. We're going to cut through the clinical density of those 100-plus pages.
There's a lot to get through.
It is. This document replaces the 2018 guideline, and the 7 years since have just seen an explosion of new evidence. The shift here isn't just, incremental. It's a wholesale change in how we evaluate and treat the adult congenital heart disease, or ACHD population.
And that population, for the first time in history, now actually outnumbers the pediatric population with congenital heart disease.
That's the key statistic. It's the whole reason this guideline is so vital. More and more children are surviving these incredibly complex congenital repairs, but they're now entering adulthood with unique and often failing anatomies.
So the problem has shifted from pediatric survival to adult management.
Precisely. The core philosophy driving this 2025 update is really a move toward proactive, standardized, and specialized management. It demands detailed risk stratification tools, it mandates multidisciplinary involvement, and it leverages high-resolution modern imaging like cardiac MR-CMR to guide these critical decisions.
So it's about not waiting for the patient to become symptomatic.
Exactly, not waiting for them to hit a crisis point.
Okay, let's unpack this. This deep dive boils down to essential, actionable changes across the board. We need to look at how they've redefined risk, how they updated management of complex physiologies like, say, chronic cyanosis, and crucially, how they move the goalposts for when to intervene in major lesions like tetralogy of Fallot.
A great place to start is with the architecture of care itself, the fundamental structure they want all ACHD diagnosis to be built on.
The classification system.
It's a classification system. The foundational tool of these guidelines is the long-established but now significantly refined anatomic and physiological classification system, the AP system.
And this isn't just a descriptive label, right? This is a tool with predictive power.
It's a critical predictive tool.
Yeah.
Extensive research confirms that a higher AP classification is directly associated with a greater risk for short and long-term mortality, worse surgical outcomes, and significantly higher risks during major life events, like pregnancy.
So if I understand it correctly, the system works kind of like a grid. The anatomic complexity gives you the baseline, the sort of immutable risk category, how difficult the plumbing is, and then the physiological stage tells you the current status of the engine.
That's a perfect way to frame it. Anatomic complexity ranges from simple, which is class 1, up through great complexity, or class 3.
Okay, so walk us through that gradient. What falls into that middle category, moderate complexity?
Certainly. So moderate complexity, or anatomic class 2, includes lifelong conditions that are serious, but often involved successful biventricular repairs. So we're talking about patients with repaired tetralogy of Fallot TOF, which is the most common cyanotic lesion.
Right.
Also things like Epstein anomaly of the tricuspid valve or repaired coarctation of the aorta. Now, while they need specialized follow-up, these patients usually have 2 functioning ventricles.
Okay, and when we step up to great complexity, class 3, that's where the physiology becomes, well, totally alien to standard cardiology practice.
Absolutely. Class 3 includes the most challenging anatomies, primarily those that rely on a functionally single ventricle. The defining example here is Fontan physiology.
Which covers things like hypoplastic left heart syndrome.
Exactly. HLHS, tricuspid atresia. These patients lack a subpulmonary ventricle, so they're relying on passive flow to the lungs. Class 3 also covers conditions involving ventricular inversion, where the systemic ventricle is actually the morphological right ventricle.
So things like congenitally corrected transposition or patients who are decades out from an old atrial switch operation.
That's it. Now, let's look at the other axis of that grid, the physiological staging, stages A through D. This is the dynamic part that tells you if the patient is stable or, moving toward decompensation.
And the guideline added some critical red flags here.
They did. Stage A is your baseline, normal hemodynamics, no symptoms. Stage B is where you start to see mild issues pop up,
Oh,
maybe some mild ventricular enlargement or dysfunction, or perhaps a pacemaker or ICD has been placed but hasn't delivered any therapy in the last year.
okay. Stage C then sounds like the beginning of, a real immediate concern.
It is. Stage C includes moderate or severe ventricular dysfunction or the presence of a hemodynamically significant shunt.
And they define hemodynamically significant very rigorously now.
Very, a pulmonary to systemic blood flow ratio, or QPQs, of 1.5 or greater. Also, and this is important, stage C includes any sustained tachyarrhythmia that required active treatment within the past 12 months.
And what about the highest risk group, stage D? That's advanced disease, and there's a very specific new inclusion from the 2018 guideline.
Right. Stage D criteria are still severe. NYHA, functional class thigh or IV symptoms, Eisenmenger syndrome, or severe resting hypoxemia. That's 85% oxygen saturation or below. But the new critical inclusion, designed to flag immediate high mortality risk, is endocarditis in the prior 1 year.
Wow. So any patient who has recently battled that infection is automatically in the highest physiological risk bracket.
Immediately. It makes perfect clinical sense. Endocarditis is a known catastrophe in the ACHD population because of, the damaged valves, the complex shunts. Classifying the survivor immediately as stage D ensures they get the highest level of vigilance.
It's an actionable red flag woven directly into the classification system.
Exactly. And this heightened awareness of risk ties directly into the next core principle, the mandatory setting for care.
We've used terms like specialized care and expert centers, but the guideline moves beyond just suggesting these. It really mandates them for complex patients. But before we get into that, you're using terms like COR1 and LOEA. Can you quickly explain what those mean for our listeners?
Absolutely. It's crucial context. When we talk about these guidelines, the language is very structured. COR stands for class of recommendation, and LOE is level of evidence.
So it's about how strong the recommendation is and how good the data is behind it?
Precisely. COR1 is the strongest mandate. It means the treatment is recommended because there's strong evidence of benefit. It should be done.
And COR2 is more of a maybe.
Sort of. COR2A means it is reasonable. The evidence is moderate. COR2B is weaker. It may be considered. And then COR3 is critical. It means there's no benefit, or even that the procedure is potentially harmful and should not be done.
Got it. And LOEA is the best evidence.
LOEA is the highest level based on multiple randomized trials. So a COR1 LOEA recommendation is essentially an undeniable clinical mandate based on the best data we have.
Okay, perfect. So with that in mind, what is the first major mandate?
The very first COR1 mandate is that all adults with ACHD benefit from routine care at specialized ACHD centers. And this is based on, robust mortality data showing better outcomes in this model of care.
And this mandate doesn't just stop at routine checkups, it extends to the operating room, even for non-cardiac problems.
That is a huge point of implementation and a COR1 necessity. Any patient who is classified as moderate or complex ACHD, so AP classes IC through D, IIA through D, IIA through D, who undergoes any cardiac or non-cardiac procedure, must have mandatory involvement from an ACHD cardiologist.
For risk stratification, planning, everything.
Everything. Risk stratification, procedural planning, and post-procedural management.
So to make that real, if a patient with, say, Fontan physiology needs an emergency appendectomy at a local hospital, the ACHD specialist has to be involved, even if it's remotely.
Exactly. The source material really emphasizes that ACHD patients present with challenges like managing fluid balance in a passive Fontan circulation or dealing with high vascular resistances that are just completely foreign to standard anesthesiology or internal medicine.
You can't just extrapolate from general heart failure guidelines.
It's often inappropriate and can be dangerous.
Right.
Having that ACHD expert input dramatically improves the safety profile for these patients.
You mentioned a continuous care model. This brings us to the infamous transition gap, where pediatric patients age out of their system and are just, poof, lost to follow-up.
It's a huge predictor of death or poor outcomes, and the guidelines are exceedingly forceful about preventing it. We see a COR1 LOE, a mandate for structured, patient-centered transition education.
And this isn't just handing them a pamphlet at age 18.
No. It has to be a continuous, age-appropriate process that's explicitly designed to improve patient knowledge and, crucially, to reduce that loss to care.
What are the biggest barriers that the sources cite for why this happens?
They pinpoint a few key systemic failures. First is just tracking. There's a lack of standardized patient identification flags in electronic medical records, in the EMRs, for ACHG patients. It makes it hard for the system to even find them.
So they just fall through the cracks.
They do. Second is staffing. There's inadequate staffing for nurse navigators and social workers whose job it is to shepherd these patients through the process. And third are the logistical barriers navigating insurance changes, the sheer distance to specialized clinics, things like that.
It sounds like a heavy administrative burden on hospitals, but it's framed as a clinical necessity.
It is, and they make it data-driven. The high mortality rates associated with loss to follow-up basically turn this administrative issue into a clinical quality and safety issue. The guidelines are signaling that institutions have to prioritize this infrastructure. The responsibility is on the system, not just the patient.
Okay, so we've established the specialized structure of care. Let's move to some of the most high-stakes personal decisions a patient and their team will ever face. Things like family planning and pregnancy.
Section 3 covers these critical general principles, and the updates on reproductive health are very comprehensive and structured to ensure patient safety.
This is where that proactive approach really shines, I think. How does the guideline ensure patients approach family planning safely?
It's a COR1 recommendation that the process begins early with preconception counseling for all adults who might be interested in a future pregnancy.
Not just women, but all adults.
All adults. And this counseling has to be robust, involving collaboration with an ACHD cardiologist. And it must outline the 3 critical risk domains: maternal cardiac risk, obstetric risk, and fetal risk.
And for patients whose underlying condition poses a life-threatening risk.
The guideline is unequivocal, also CR1. Patients who are identified as having a high risk for maternal morbidity and mortality, think severe pulmonary hypertension or a very low ejection fraction, must be counseled to avoid pregnancy entirely.
And they have to be provided guidance on contraception.
Detailed guidance on the most effective and safe options. And this is a critical corollary, the guidelines state clearly that for high-risk pregnancies, the option of termination must be discussed as part of that comprehensive risk reduction counseling.
Ensuring the patient is fully informed of all available medical pathways.
Exactly.
Now, beyond the counseling, what is the major warning sign about ongoing contraception choices for these patients?
This is a major safety alert. The guidelines singles out the high-risk intersection of cyanosis and estrogen. For patients with ACHD and chronic cyanosis, estrogen-containing oral contraceptives must be strictly avoided.
Because of the blood clot risk?
Exactly. The increased risk for thromboembolic complications, including stroke. Progestin-only methods are generally much safer alternatives in this specific group.
So that's a really clear, actionable piece of advice.
It is. And of course, once patient is pregnant, the need for specialized care continues. It's a COR1 mandate that these patients be managed in close collaboration with a cardio-obstetrics team that has specific expertise in ACHD.
Okay, let's move to another fascinating physiological deep dive. Chronic cyanosis. This section feels like a major paradigm shift because it fundamentally attacks a harmful decades-old clinical practice.
This is maybe the clearest clinical correction in the entire guideline, and it's visualized beautifully in Figure 1 of the source document. We have to start with the mechanism. So when a patient is chronically hypoxemic low oxygen, the body tries to compensate by making more red blood cells.
Secondary erythrocytosis.
Right. But this increased demand for red cells often outstrips the body's iron supply, which leads to iron deficiency.
So the patient is producing too many cells, but the cells themselves are, poorly functional.
Exactly. They're small, they're ineffective at carrying oxygen. And this state, a high red blood cell count but low iron, paradoxically makes oxygen transport worse and leads to symptoms like headache, fatigue, and increased stroke risk from hyperviscosity.
So the high red cell count doesn't mean better oxygen delivery. It actually means the system is failing and starving for raw material.
Precisely. And this leads to the first powerful COR1 mandate. Patients with ACHD and cyanosis should undergo annual screening and receive treatment for iron deficiency.
Even if their hematocrit is elevated?
Even if their hematocrit is elevated, you have to optimize the quality of the red blood cells, not just the quantity.
Okay, now let's tackle the historical elephant in the room. Prophylactic phlebotomy, just removing blood to thin it out.
The guideline is incredibly firm here. It is an explicit COR3, no benefit recommendation. Prophylactic phlebotomy should not be performed.
Because it just makes the iron deficiency worse.
It makes it significantly worse, provides only a transient benefit, and most alarmingly, it actually increases the patient's risk for stroke. We are now advised never to use it in asymptomatic patients.
So if a patient is symptomatic, say, with severe headaches from the hyperviscosity, what is the mandated management sequence now?
The flowchart is mandatory and sequential. If the patient has hyperviscosity symptoms, step 1 is assess hydration. If they're dehydrated, rehydrate. That's COR1.
Okay.
Step 2, assess for iron deficiency. If it's present, treat the iron deficiency. Also COR1. You address these two correctable issues first.
And only then can you even think about phlebotomy.
Only then. Phlebotomy is only a consideration, a COR2B, if the symptoms persist despite adequate hydration and iron deficiency treatment, and D, that the patient's hematocrit is over 65%.
And even then, it's done very carefully.
Very carefully. A small volume, 250 to 500 millirel, removed slowly with simultaneous volume replacement to maintain stability. The goal is to maximize oxygen delivery, not just thin the blood.
That is a fundamental, potentially life-saving clinical correction. It really is.
It is. And this vigilance also necessitates a COR1 mandate for neurologic surveillance. Any cyanotic patient with new or worsening neurologic deficits needs urgent brain imaging to exclude a cerebral abscess or stroke.
Okay, let's shift gears slightly. Integrating genetics into standard cardiology guidelines shows just how holistic this care has become. Why is genetic screening now suggested for so many ACHD patients?
Well, genetic evaluation is suggested. It's a COR2A recommendation, especially if there's a family history or clinical features that suggest a known syndrome. The rationale is threefold. It guides current management, it informs the patient and their family about long-term prognosis, and it's crucial for family planning.
Can you give us a specific, actionable example of how a genetic diagnosis changes the cardiac treatment plan right now?
Two syndromes perfectly illustrate this. The first is Williams syndrome. These patients have a deletion on chromosome 7 that causes an elastin arteriopathy,
Which puts them at high risk for coronary problems.
a very high risk for supravalvular aortic stenosis and, critically, coronary osteostenosis. Because of this coronary risk, which heightens the threat of sudden cardiac death, the guideline issues a COR1 recommendation for baseline coronary imaging in these patients.
So you proactively screen for coronary blockages even if the patient has no symptoms because the risk is just inherent to the syndrome.
Absolutely. The sources specifically note that a standard ECG often fails to detect ischemia in these patients, so relying on symptoms alone is just insufficient and dangerous.
Wow. Okay, and what about Noonan syndrome?
Noonan syndrome is complex, often involving pulmonary valve stenosis. But critically for any surgical planning, it's often associated with platelet dysfunction or coagulation factor deficiencies,
So a higher bleeding risk.
an inherent increased bleeding risk. Knowing this allows the multidisciplinary team, the surgeon, the hematologist, the cardiologist, to implement targeted preoperative protocols to mitigate that bleeding risk well ahead of any invasive procedure. It helps anticipate non-cardiac risks that can profoundly impact recovery.
Okay, we've covered the structural demands and the big physiological principles. Now let's get into the disease-specific sections. This is where the shifts in objective intervention thresholds are maybe the most dramatic.
This is where that proactive philosophy translates directly into changing the timing of these life-altering procedures.
Let's start with tetralogy of Fallot, the most frequent complex lesion.
Right. So repaired TOF patients usually develop severe pulmonary regurgitation over time. This leads to chronic volume overload and dilation of the right ventricle, the RV. And the central clinical debate has always been, when should we perform pulmonary valve replacement, or PVR, to protect that RV from irreversible damage?
The 2018 guidelines focus heavily on the RV-N diastolic volume index, the RV-EDVI. That's essentially the maximum size of the stretched out ventricle before it contracts.
Yeah.
Why is that metric now considered potentially too late?
That's the most massive clinical change here. Think of RV-EDVI as the maximum capacity of a stretching rubber band. How far it can stretch when it's full of blood? If you wait until that number is too high, it means the RV wall has already suffered severe, often irreversible chronic injury.
So the damage is already done.
Exactly. The 2025 guideline shifts the focus to the right ventricular end-systolic volume index, or RV-ESV.
What does RV-ESV measure and why is that a better trigger?
RV-ESV is the amount of blood left in the ventricle after it tries to contract. It's the residual volume. And that's a much better marker of the RV's inability to empty itself, a direct sign of failing contractility and irreversible myocardial injury.
So we're moving from how much the heart stretches to how well it actually squeezes.
That's the perfect way to put it. We're intervening based on the failure to contract, not just the overstretching.
It's a huge shift. We're proactively trying to protect the heart muscle before the damage really sets in. What are the new objective metrics for intervention?
For an asymptomatic patient, The guideline now says PVR is reasonable, COR2A or 2B, if they meet two or more of several specific objective markers. And the new thresholds are 1. RV ESVI greater than 80 millilem 1F.
That's the new magic number.
That's the new tipping point. 2. A right ventricular ejection fraction, or RVEF, less than 36%. 3. A left ventricular ejection fraction, LVEF, less than 50%.
That's interesting, including the LVEF.
It's crucial. Severe RV volume overload often impacts the left ventricle, and the guideline recognizes this biventricular failure as a sign to intervene.
And with this shift to such precise metrics, the tools you use to measure them must also be high fidelity.
Absolutely. This justifies the COR1 mandate that cardiovascular magnetic resonance imaging is recommended for quantifying all of this valve function, ventricular volumes, even assessing myocardial fibrosis.
It's just so much more reproducible than echo for the RV.
Far superior for the complex geometry of the RV. And furthermore, for transcatheter PVR planning, cardiac CT is explicitly recommended, COR1, to determine anatomic suitability and, critically, to assess the risk of coronary artery compression.
Let's talk about arrhythmia management. It's a huge driver of morbidity in TOF patients because of all that ventricular scarring.
It is. And in patients who are getting appropriate ICD shocks for monomorphic VT, adjunctive catheter ablation is now deemed reasonable, COR2A, to reduce that burden and just improve their quality of life.
And there's a crucial timing consideration here regarding ablation and the PVR surgery itself.
Yes. The guidelines suggest that you should consider a preemptive EP evaluation and possible ablation before the PVR. The reason is that when you place that prosthetic valve, the material can make it really hard or even impossible to get catheter access to the arrhythmia circuits later on.
So you address the electrical problem first while you still can.
It preserves your future treatment options.
Okay, let's move to another incredibly complex group, patients with Fontan palliation.
All right, the Fontan circulation is a testament to surgical ingenuity, but it's a fragile, non-physiologic system. It relies entirely on passive venous return. So the guidelines focus heavily on preventing the three major catastrophic complications: arrhythmia, thrombosis, and circulatory failure.
For arrhythmias, which can be devastating in this low-flow system, what's the COR1 mandate?
The priority is timely cardioversion. It's COR1 for any new onset atrial flutter or fibrillation. In a Fontan, that passive flow to the lungs is incredibly sensitive to heart rate. A rapid rate severely compromises venous return and causes an immediate catastrophic drop in cardiac output.
So you have to act fast.
You have to act fast, whether it's pharmacological or electrical, to restore sinus rhythm.
And on the thrombosis front, the stagnant flow through that Fontan pathway makes these patients notoriously prothrombotic.
It does. High-risk patients, so those with a history of atrial arrhythmia, a prior thrombus, or the older atriopulmonary Fontan, they require chronic anticoagulation. The guideline acknowledges the limited but growing evidence that direct oral anticoagulants, the DOACs, may be safe and effective here.
So maybe comparable to warfarin?
They could be considered comparable, though the data is still less robust than for warfarin. But the shift toward DOACs for convenience is definitely noted.
Yeah, okay. Moving to the end of the line. Fontan circulatory failure, which often means transplantation.
Early referral to an advanced heart failure program is just paramount. Durable mechanical circulatory support, or MCS devices, are now considered reasonable, CR2A, as a bridge to transplant or even as destination therapy.
But a huge complexity here is Fontan-associated liver disease, or FALD. The chronic venous congestion just destroys the liver over time.
It does, often leading to cirrhosis. And this forces the incredibly tough decision of whether to do a heart-only or a combined heart-liver transplant.
Which is where medicine becomes more art than science.
It really is. You're managing multiple failing organs at once. While a combined heart-liver transplant can work, the initial post-operative period is just fraught with complications. The guideline emphasizes that the specific indication for combined versus heart-only is still a major challenge.
Because sometimes the liver function improves after just a heart transplant?
Exactly. The dysfunction might be reversible. So expert hepatology evaluation at the time of referral is mandatory to tailor that transplant strategy.
Okay, let's move to coarctation of the aorta, or COA. It's often repaired in childhood, but the long-term risk of hypertension and vascular complications just persists throughout life.
And that residual risk necessitates mandatory surveillance. The first key recommendation is COR1. Periodic cross-sectional imaging, either CMR or CT, is essential for patients with repaired COA. This is lifelong screening.
You're looking for recoarctation Aneurysms?
Recoarctation, aneurysm development, especially in the ascending aorta and other complications at the repair site. For stable patients, maybe every 5 years, but for those with known issues, it has to be annual.
What new objective metric is guiding the intervention threshold for recoarctation?
So intervention is recommended for hemodynamically significant COA, that's COR1. But while the pressure gradient is still important, the new guideline highlights empiric data suggesting the aortic isthmus ratio of less than 0.7 may be the optimal anatomical threshold for intervention.
What does that zero point 0.7 ratio mean, and why is it better than just looking at the pressure difference?
The ratio compares the diameter of the narrowest part of the coarctation to the diameter of the descending aorta. And studies indicate that intervening when that ratio falls below 0.7 maximizes the likelihood of left ventricular hypertrophy regression.
The thickening of the heart muscle.
Right. So by intervening at this threshold, you are proactively preventing chronic pressure overload on the left ventricle. You're intervening not just to fix the flow, but to normalize the long-term heart structure and reduce the lifetime risk of hypertension and stroke.
That's a great example of the proactive philosophy. And what about screening for acquired heart disease in this group?
Because of the high prevalence of hypertension, evaluation for coronary artery disease is deemed reasonable coronary 2A in COA patients who present with exertional symptoms. The mechanism is multifactorial, so it necessitates this focused screening.
Okay, what about a much rarer lesion, core triatriatum sinister?
Right. CTS is a rare defect where a membrane divides the left atrium, effectively mimicking severe mitral stenosis. The main concerns are the obstruction itself, arrhythmias, and stroke risk.
So how does the guideline address that high thromboembolic risk?
Because of the flow stagnation behind that membrane, chronic anticoagulation is recommended, CO1, for unrepaired CTS if it's associated with AFib, a prior stroke, or a left atrial thrombus.
And when is surgery necessary?
Surgical resection of the membrane is the definitive therapy, COR1, for symptomatic patients. But the guideline addresses a critical scenario, when the patient is too high risk for an immediate definitive surgical repair.
Like during acute decompensation or, say, pregnancy?
Exactly. Catheter-based intervention, like a balloon dilatation of the membrane, may be considered CO2B as a bridge to surgery. This is reserved for highly symptomatic adults with a high operative risk or, importantly, during pregnancy.
So it's a temporizing measure.
A crucial temporizing measure to stabilize the mother until definitive surgery can be performed safely postpartum.
Okay, to offer a final synthesis of these 2025 guidelines.
Well, I think we are seeing the field of ACHD cardiology decisively move away from just symptomatic management and toward proactive precision surveillance.
Right.
This is evidenced by so many of the shifts we've talked about, the refinement of the AP classification to include acute high-risk markers like recent endocarditis.
The mandatory multidisciplinary protocols for complex issues like pregnancy and non-cardiac surgery.
The strict sequential management of chronic cyanosis that corrects old harmful practices. And of course, the reliance on these objective, non-invasive metrics like the RV-ESVI greater than 80 in TOF and the aortic isthmus ratio less than 0.7 in COA to dictate the optimal timing of intervention before irreversible organ damage occurs.
So sophisticated imaging is no longer just a nice-to-have, it's a COR1 standard.
It's the standard for diagnosis and planning.
It's a remarkable step toward ensuring that ACHD patients don't just survive, but actually thrive through adulthood. But as you've highlighted throughout this deep dive, even the most rigorous, data-driven guidelines, well, they don't close all the evidence gaps.
No, they don't. And the document itself is honest about the remaining unknowns, which often cluster around the most complex, fragile patient groups.
So that brings us to the provocative thought for our listener.
I think so. The document points to key remaining evidence gaps. And to me, the biggest unanswered question, and maybe the one with the highest stakes, revolves around those systemic right ventricles we discussed, those TGA or CCTGA patients.
Right.
The question is, which specific high-risk systemic right ventricle patients truly benefit from a primary prevention ICD? And does that strategy genuinely reduce long-term mortality in a way that outweighs the high rate of inappropriate shocks and complications?
And the continuing struggle to answer that question really underscores a crucial reality for you, the listener. Even with the best, most detailed guidelines based on the strongest available evidence, critical, life-altering decisions in ACHD remain highly individualized.
They absolutely do.
They still require expert consensus, careful clinical judgment, and a healthy dose of humility about what the data can and cannot tell us yet. It's a field built on progress, but that progress still leaves vast territory to explore. Thank you for watching The Funnel Effect.